In the CVS, what kind of general examination you expect? Don't see that. That is wrong. I mean, that is wrong. Don't look at that. Tell. What kind of general examination? Tell. What? Tell. Markers of congenital heart disease. So what are the markers of congenital heart disease you are going to look for? What are the markers of congenital heart disease? Okay, hypertelorism, low satius. Huh? Mongolian faces, okay. What is Mongolian face? Okay, then? Huh? Kyphoscoliosis. Actually, it's not a marker of congenital heart disease, kyphoscoliosis. See, it's a marker of a number of disorders. Okay, then? I mean, because of Marfan syndrome, you're telling that. But anyways, kyphoscoliosis can result in many other lung problems also. ILD and lung disorders also. Restrictive lung disease also can happen. So then, huh? Okay, finger abnormality, syndactyly, polydactyly. Then, absent radius. Why? What syndrome you are trying to look for? Down, sir. No, absent radius is a feature of Holt-Oram syndrome. What congenital heart disease is associated with Holt-Oram syndrome? ASD, correct. So we have multiple syndromic associations. We have Downs, Turner's, Holt-Oram, Ellis-Van Creveld, charge association, D-George syndrome, Poland syndrome, Williams syndrome. Then so many associations are there with cardiovascular disease. Okay, so any one of the syndrome, if they ask you, you are dead and done there itself. But usually, fortunately, examiners will hold only with Down syndrome and Turner syndrome mostly, and Noonan syndrome. We forgot. No? Noonan syndrome is there. So any one of these syndromes can be asked. And velocardiofacial syndrome is there. Velocardiofacial syndrome, VCFS. So actually, velocardiofacial syndrome has multiple phenotypes. Phenotypes in the sense, you might be thinking D-George syndrome as a separate syndrome. But to be honest, D-George syndrome is a phenotype of velocardiofacial syndrome. Charge syndrome is a phenotype of velocardiofacial syndrome. And your one more, Peary-Robin sequence. That is not associated with cardiac problem, but Peary-Robin sequence is also a association or phenotype of velocardiofacial syndrome only. So velocardiofacial syndrome is an umbrella term that has multiple phenotypes. And most of them will be, velocardiofacial syndrome means it's associated with abnormal development of the pharyngeal arches. So D-George syndrome is also because of that. So likewise, you can explain most of the things. So we'll come back to the basics first. So when you go to the basics, you need to know what do you mean by the term cephalic index. So if you see this image, you can see in the skull, you have two diameters. You can do that with the CT also. Just with the CT head, you can do that. With the bone window, you'll be able to find out the biparietal diameter as well as occipitofrontal diameter. Biparietal diameter means the distance between both the parietal bones. And occipitofrontal diameter is between the occiput and the frontal bone. So what do you mean by the term cranial index or cephalic index? So the definition says, or the calculation says, it's BPD by OPD multiplied by 100. You need to give it in the form of percentage. That's why you're multiplying by 100. So this is called as cephalic index. We have multiple different types based on cephalic index. First type we called as mesocephaly. Second type we called as brachycephaly. Third type we are going to call it as dolichocephaly, which is very common in Marfan syndrome patients. Dolichocephalic face, straight long face. And finally we have something called plagiocephaly. So mesocephaly, brachycephaly, dolichocephaly, and we have plagiocephaly. So what is the cranial index? So cephalic index will be 76 to 81%, which is considered to be in the mean range. So mesocephaly means 76 to 81% mean range. Very commonly, this kind of skull will be seen in Caucasians, normally itself. Populations where normally seen, it's Caucasians. Brachycephaly means cranial index will be, or cephalic index will be more than 81%, which means the biparietal diameter will be relatively more than the occipitofrontal diameter, which means the primary feature here is increased biparietal diameter. That is the reason. So which means the width of the skull is little more. So which group of patients, or I mean, in which population you will normally see this? Indians, Native Americans. We're not talking about Americans, the current Americans who are migrated from Europe. We're talking about the Native Americans. Yes. Then Malaysian people, Malays, Burmese, in that area, in the belt, Malaysian Burma belt. We can call Southeastern Asia, isn't it? So those belt. So all these people generally tend to have this kind of brachycephaly only. What is dolichocephaly? Cephalic index will be less than 76%, which means here the primary feature is increased occipitofrontal diameter, which means the length of the skull is increased rather than the width. The length of the skull is increased, so the skull will be more narrow, more straight and more narrow. So this will be seen in one of the subtypes of Indian population called as Aryans. To be honest, we are all basically Dravidians. To be honest, we are not Aryans by race. Aryans are people who are currently residing in the central and northwestern part of India, or maybe North Indians you can call. So these are Aryans basically. So this specific subtype will have this kind of dolichocephaly. They might have straight face. And plagiocephaly means there is no cephalic index. It's just an asymmetric head, which means different sutures might combine and they produce a very asymmetric head. So there's nothing to do with the cephalic index there. So you don't have plagiocephaly normally in any population. It's an abnormal head. It's always abnormal. What are the sutures that are fused here? Here, the lambdoid and the coronal sutures will be fused. Generally, that's the reason you get brachycephaly. The sagittal sutures will fuse here. That's why it's called, that's why you get the dolichocephaly. And in plagiocephaly, again, abnormal fusion. All may be fused, or one or more sutures may be fused at an abnormal location at an irregular interval also. So any suture can be, all or any suture can be abnormally fused in these patients. So the primary feature here is the asymmetry of the skull. Asymmetry in the sense like different areas of skull will look differently. That is what we call as plagiocephaly. Always almost abnormal. It's never seen in any normal individuals. But remember, meso, brachy, dolicho. In that, meso is considered to be a normal variant. Maybe because of white people believe that they are superior. They say like mesocephaly is considered to be normal head, Caucasian race. Brachy and dolicho also is normal only. Okay, unless until it's extremely abnormal. But it can be seen in certain disorders also, like dolichocephaly and Marfan syndrome. Very common feature. So it can be normal or it can be abnormal. But plagiocephaly is almost always abnormal. It can never be normal. And once again, heart rate, respiratory rate, and blood pressure is also something very important. You need to know before discussing the cardiology. Okay, this is very important because different age group will have different heart rate, different age group will have different respiratory rate, and different age group will have different normal blood pressure. So you need to know that. So tachycardia. What is the definition of tachycardia in adults? Heart rate more than 100. If it's less than 60, we are going to call it as bradycardia. This is straightforward and pretty normal. Everyone knows this. On the other hand, if it is school-going children, the definition remains the same. Okay, definition remains the same in school-going children. Suppose if it's a preschool child, more than 110 we call it tachycardia and less than 65 we call it bradycardia. In toddlers, more than 110, less than 70. And in infants, more than 120, less than 90, and in newborns, more than 160 and less than 100. Remember, in a newborn child, heart rate less than 100 is bradycardia. Whereas in adults, heart rate more than 100 is tachycardia. Okay? In adults, heart rate more than 100 is abnormal. In newborns, heart rate less than 100 is abnormal. That's what you need to know. Okay, that's why heart rate differs widely with age group. So is the respiratory rate. You know the adult respiratory rate, already I told you yesterday. The beginning, when I'm talking about dyspnea itself, I told you it's 12 to 20. That's normal. In school going children, it is around 18 to 30. In preschool children, it is 22 to 34. In toddlers, it's somewhere around 24 to 40. In infants, 30 to 60. Newborns, 40 to 60. Okay, having a respiratory rate of 40 in a newborn is fairly normal. It is not tachypnea. Similarly, blood pressure also is going to be different. So the most important definition is hypotension rather than hypertension. For example, you know, in adults, the standard definition of hypotension is if the BP is less than, systolic blood pressure is less than 90 millimeters of mercury. That is the standard definition of hypotension in an adult individual or anyone more than 10 years of age. 1 to 10 years of age, we have a formula. The lower limit of systolic blood pressure is 70 plus 2 times the age. This is the normal, this is the lower limit. I'm not telling about the normal BP. I'm talking about the lower limit of normal, which means if the BP is less than that predicted by that formula, it is hypotension. 70 plus 2 divided by age. I mean 70 plus 2 multiplied by age, 2 times the age. And in infants, 70 is considered to be the lower limit of normal, which means anything less than 70 in an infant is hypotension. And in newborn, it is 60 millimeters of mercury. So less than 60 in a newborn is considered hypotension. Okay, so the BP, pulse rate, heart rate, everything varies with age. That's one thing that we need to know, because when you are talking about congenital heart disease, if you're going to get a congenital heart disease case in your exam, even if you're going into medicine, examiner will ask you this. Suppose what if a 10-year-old boy is placed in a medicine ward for VSD? So you can't predict these things and all. Generally, it happens very commonly. Sometimes, you know, like if they don't get the congenital heart disease case and the examiner is adamant about some congenital heart disease, they might pick a case from pediatrics also. It's very common. It happens in my hospital. I don't know how much it happens here. It happens very commonly there. They pick a case from pediatrics ward, maybe 11 or 12-year-old child, and they'll keep there. And you know, like whenever a congenital heart disease case comes, no, examiner's hands will be like this always. You know what does this mean? Okay, they will come with full-fledged. They will be very ready to fire all cylinders. Okay. That's why you have to be very careful. Actually, my medal exam case was in Tamil Nadu. Locally, they keep a medal exam. Okay, so my medal exam case was a case of tetralogy of Fallot with dextrocardia. That was my case. And actually, the duration that they'll give is in medal exam, they won't keep the usual schedule. I mean, at least in our area, they don't keep the usual schedule. They will give 8 cases. Each case 15 minutes time, 2 hours time total. It can be any case. There will be a cardiology case. There will be a neurology case. There will be a respiratory case. There will be one rheumatology case. One rheumatoid arthritis will be there with deformities and all. Endocrine case, Graves' disease they will keep with ophthalmopathy and all. So there will be 8 cases. Serially, I got like there will be 2 sets of rounds will be there, and cases will be decided randomly. There will be 20-25 cases. Randomly they will choose, so that you should not know what case you will get. So that will be a bias, right? So I got a case of coarctation of aorta. I mean, myself and one of my friends were deemed to be very unlucky because we got extremely tough cases. Coarctation of aorta, one Parkinson plus, that is progressive supranuclear palsy, and I got this TOF with dextrocardia. So very, very tough cases. One rheumatoid arthritis, polymyositis. So these are the type of case I got. And one advantage of getting tough case in exam is you will pass easily and they will give extra marks. Because they know, Pao, he's getting all tough cases. The thing is, if you get an easy case, You are done and dusted. That is why when you go to the exam hall, always, if you get a tough case, never be boggled down. The questions will be pretty easy and straightforward. They're going to ask only few questions. But if you get a very common case, if you don't answer questions properly, then there is a lot of chance that you may fail. I told this because you should know, when you go to the exam hall, sometimes you may get a tough case or a case you may not be intending to get. You're not planning to get. Because I've seen a lot of juniors, after coming to the exam hall, says, please sir, respi case sir. Sir, please sir, abdomen case sir. They don't want neurology case at all. And where I will go for all respi and abdomen cases. Because all they want is abdomen, long case itself. So easy man, abdomen alone. But anyway, if you don't answer correctly, same girl who asked for abdomen case, I gave abdomen case. Okay, that girl I told you, no? Same girl I gave abdomen case. I tried my best to save her. Okay, she got abdomen and but ultimately, examiner asked, what is the treatment of varicose bleeding? She told heparin. I got like this. Now nothing can be done. I cannot help anymore. Only I can console. What else I can do? Say, I'm always available for consoling. But what else I can do? So she really answered this. I don't really understand why she answered this, but she really answered treatment of varicose bleed. Maybe she got confused with something else. I don't really know what's going in her mind that time. She got very much confused and started varicose bleed. You only asked cirrhosis case. That's why take the case what you have got. That is very, very important. Okay, don't argue with the PGs. There, I want this case only. I want that case only. Okay, so this is an example of a brachycephalic head, like more wider head. So this is mesocephalic, considered to be normal, and this is dolichocephalic, where your face will be more straighter and longer. And the dental arches also will vary based on your facial features, your cephalic index. For example, in brachycephaly, your dental arch will be very broad. It will be very wide, as you can see. Whereas in dolichocephaly, your dental arch will be narrow, but it will be very long. Dental arch will be narrow and very long. And in mesocephaly, it is called average. That's considered to be normal, I said, no? So there will be paraboloid. It will not be very wide also. It will not be very narrow also. It will be average, called as paraboloid. So this is the different type of dental arches that you will encounter in patients' cephalic index. To be honest, in my congenital heart disease discussion, they asked this one, the cephalic index and the different types of dental arches. And my examiner asked the method to find out the high arched palate. What is the definition of high arched palate? That was the question given to me. Unless until you know that, it's impossible to answer these questions. Okay, you cannot just go and, it's not an MCQ exam. You can just ignore one or two options and select the best option. There's nothing like that. If you don't know, you don't know. That's all. You cannot blabber around. High arched palate, very difficult. So that's why congenital heart disease, you need to be extremely careful. So that's why she said markers of congenital heart disease. Hyper, hypo, so many markers she said. But generally, what are the markers that you expect? So we have hypertelorism, we have hypotelorism, and you have multiple other things also. Okay. So for that, you need to know some important diameters. First of all, what are the important diameters that you need to know? First one, it's very easy to understand. You can yourself say what is B stands for. What B stands for? Inner canthal distance. Okay, don't tell inter. You have two canthus, outer canthus and inner canthus. What canthus you mean? This is inner canthal diameter. Cool. This is an inner canthal diameter. And second one, you have one more thing. This is A. What is this? This is interpupillary distance. Okay, that's IPD. That's called interpupillary distance. And then you have C. What is this? Outer canthal diameter. That's called OCD. Outer canthal diameter. So you have inner canthal diameter, you have interpupillary distance, and you have outer canthal diameter. Based on this only, you are going to define different hypertelorism or hypotelorism or whatever it is. For example, so what is the definition of hypertelorism? So there are many different types of hypertelorism. We have ocular hypertelorism and we have orbital hypertelorism also. But general definition of hypertelorism is ICD by OCD more than 0.38. Okay, if your inner canthal distance by outer canthal distance, if it's more than 38%, that is 0.38, we can call it as hypertelorism, which means your inner canthal distance is increased. Okay, that's what the idea is. Do you understand? Your inner canthal distance is increased. That's what I mean by hypertelorism, basically. In that, some authors will give you two different kinds of definition. One is called as ocular hypertelorism, as I told you. Another one is orbital hypertelorism. So if your interpupillary distance is increased, okay, if your interpupillary distance is increased, they call it as ocular hypertelorism. If your primary problem is increased interpupillary distance, that's called ocular hypertelorism. And if your inner canthal distance is increased, that is called as orbital hypertelorism. And some authors describe two different types of hypertelorism itself. If interpupillary distance is increased, that's called ocular hypertelorism. If inner canthal distance itself is increased, that's called orbital hypertelorism. Okay, there are two types, but general consensus says that definition of hypertelorism is ICD by OCD more than 0.38. Similarly, if your ICD by OCD is less than 0.33, it is called as hypotelorism. If it is less than 33%, less than 0.33, it is called as hypotelorism. Clear? So I'm giving little time just to draw the eyes. I know you don't have the eyes in your note, so that's why I gave a little bit of time. Okay. So then she said something called as low set years. Okay, so what is the definition of low set years? Okay, normally whenever you draw a line from the outer canthus, not from the inner canthus, if you're going to draw a straight line from the outer canthus, this straight line should exactly meet the upper 1/3 and the lower 2/3 of the ears. Okay, that is normal. Even if you see your friend or yourself in the mirror, you can able to see that. Okay, or you can also note one other point, that this line will intersect at the root of the helix. You know, this is the helix, right? So you can see this is the root of the helix. It will exactly intersect at the root of the helix. This attaches, no? This is the root of the helix. This pinna attaches, no? That's the root of the helix. So that will exactly intersect at the root of the helix. That is the normal ear position. But if the ear is located below this line, then we are going to call it as low set ears. Do you understand? So a line that you draw from a straight line that is drawn from the outer canthus should intersect at the root of the helix, or it should intersect at a point of upper 1/3 and the lower 2/3 of the earlobe. So if the ears are located below that, then it is called as low set ears. I'll show the obvious examples. Then she didn't say few other markers of congenital heart disease. One is called as low posterior hairline. I mean, because if you say low hairline, you mean it's posterior hairline only, but examiner will ask, anterior also you have hair, no? Then what do you really mean? So that's why answer it as low posterior hairline. So what is the definition of low posterior hairline? For that, you need to know certain important landmarks. What are the landmarks? First is something called external occipital protuberance. External occipital protuberance. And second landmark is the hairline itself. First, external occipital protuberance. And the second landmark is your hairline. And the third landmark is the C7 spine. It is not mentioned here. Third landmark is C7 spine. C7 spine is the most prominent spine. Everyone knows that. Just by touching on the back, you will be able to see the C7 spine. It's easily palpable. Okay. First thing what you need to know is, from the external occipital protuberance to the C7 spine is the definition of anatomical neck. You would have studied in first year itself. That is the definition of neck actually, anatomical neck. Neck starts from the external occipital protuberance and extends till the C7 spine. That is the definition of anatomical neck. So you are going to split into this anatomical neck, you are going to split into two parts. One is the first part, which is A, which is going to extend from your external occipital protuberance to the hairline. And second is part B. Part B is from the hairline towards the C7 spine. That is B. So generally speaking, even though diagrams will not show adequately, generally, if you take the ratio of A by B, usually A will be much lesser, B will be very high. Which means from the hairline to C7 spine, the distance will be more compared to the external occipital protuberance to the hairline. So if you see external occipital protuberance to hairline line will be this much, but till C7 spine it will be this much. So if you take the A by B, if it is more than 0.17 in males, or if it is more than 0.25 in females, more than 0.17 in males, or if it is more than 0.25 in females, it's considered to be the definition of the low posterior hairline. Or alternatively, you can say in males if it is more than 1/6, or in females if it's more than 1/4, you can say it is abnormal. The hairline is very deeper. That's what means it comes down. That's called low posterior hairline. This distance A, that is from external occipital protuberance to hairline, and distance B, that is hairline to C7 spine. If it is more than 1/6 in males, that is 0.17, or if it's more than 1/4 in females, that is 0.25. If it is the case, then you can call it as low posterior hairline. I'll tell you some of the conditions that are associated with low posterior hairline later on. And apart from that, I've asked you about the definition of the high arched palate, isn't it? So when you call the palate as high arched in the first place, for that you need to have certain definitions for that, for the same palate as high arched palate. So first you need to know palatal height. Okay, palatal height. So at what point you will measure the palatal height? It's the first molar. Okay, so you know teeth, what are the types of teeth we have? We have incisors, we have canines, premolars, molars. We have first molar and second molar. Isn't it? Yes or no? Third molar is wisdom teeth, it will be very painful. Okay, we have two molars, first and the second molar. So at the level of the first molar only, ideally you have to measure. And see, horizontal level, you know, it is at the level of first molar. But vertical height, you don't know at what point you need to measure, because palatal is something that is arching. So you don't know exactly at what level. So that level is considered to be the junction of the soft and the hard palate. So initially you have the hard palate. Then in the posterior area, you're going to have a soft palate. So there will be a point where there will be a junction of the hard and the soft palate where you can look in the X-rays, especially lateral X-rays, it will be very clear. So what you're going to do is, you're going to draw a line from the junction of the soft and the hard palate towards the first molar. Clear not? Towards the first molar. So this is considered to be the height of the palate. PH stands for palatal height. That is the height of the palate. Okay, or we can call it as height of the arch of the palate, whatever. That's considered to be the palatal height. So some variations in this definition is there because there is no universal standard definition. This definition, what I have took is from Perloff. Perloff is one of the classic textbooks for pediatric cardiology. Okay, so all congenital heart diseases. So this definition is given in Perloff. So first molar in the horizontal axis and the junction of the soft palate and the hard palate in the vertical axis. But some Indian variations will be there. So what they are saying in Indian textbooks is you have to take the shortest distance. See, the vertical diameter, vertical point is fixed, vertical plane is fixed. That is the junction of the soft and the hard palate. But what they are saying is from this point, you have to draw a line that has the shortest distance. It doesn't mean that you have to, that it has to go through the first molar. It can go through what? The premolar also. It can go through what? First molar also. It can go through what? Second molar also. Or it can go through what? The canine teeth also. It doesn't matter. But it has to be the shortest distance. But in this diagram, if you see, the distance between the premolar and the midpoint, junction of the soft and the hard palate is the shortest distance in this diagram. Because if I'm going to draw like this becomes what? Long or short? Long. So they are saying it should be the shortest distance. That's another variation of the definition. So standard definition says it should be the first molar in horizontal plane and the junction of the soft and the hard palate in the vertical plane. But some variant definition says that it need not be first molar. The vertical plane is fixed. That should be the this thing. What is that? Junction of the soft and the hard palate. But the line that can be drawn in the horizontal plane that touches the horizontal plane can be any one of the premolar, molar, or even a canine, but it should be the shortest distance possible. So that is considered to be the height of the palate or the height of the arch of the palate. So now, how to find out the palatal width? Palatal width, you have a standard definition. It should be done only at the level of the first molar. Okay, this is the first molar. And after that, you have the second molar. Before that, it's the premolar. So palatal width should be always at the level of first molar only. So now come to the definition of high arched palate. So what is the definition of high arched palate? Generally, if you take the whatever teeth you are using, like for measurement, I told you any teeth you can use, but whatever teeth you are using, you have to take the height of the teeth. Okay, height of the teeth. And generally your palatal height is there, no? The roof of the palate, the vertical measurement, the palatal height that you have measured should be less than 2 times the height of the teeth. Suppose if your palatal height by this measurement, if it is more than 2 times the height of the teeth that you are using to measure, that is considered as high arched palate. Okay, this is an example of a high arched palate, what I have shown you there. Because definitely in that example, the height of the palate is surely more than 2 times that of the teeth. Do you understand? As simple as that. That's all. Generally, the height of the palate will be less than 2 times the height of the teeth itself. If it's more than 2 times the height of the teeth, that is considered to be high arched palate. Okay, in exam, how to explain this is a big problem. Okay, how to say the definition? It's pretty simple. But the examiner will ask all the details if he gets confused. So you have to be very crystal clear in your definition when they ask palatal height more than 2 times the height of the teeth itself. That is the definition of high arched palate. If you say this one line, nobody will question you anything more. You cannot explain this and all to the examiner. I explained to you because you need to know what does it mean. Okay, so this is the exact definition of high arch palate, to be honest. Yeah. Then these are some of the examples of your markers that you have seen right now. So what is this one? It's easy to say. What is this one? This one is hypertelorism, man. I'll talk about that later on. You are going to say this is Eppert syndrome or Cruzen syndrome or fever syndrome. But this is, you have multiple syndromes, right? FGFR related mutations. Fever, Eppert, Cruzen. So many syndromes are there. This is hypertelorism. It's very clear. See how much distance is there between the to inner canthae. That itself says it's a hypertelorism only. And these are examples of hypotelorism. Hypotelorism. And this is an example of, she said, mongoloid facies. It's not mongoloid facies, it's mongoloid slant. Okay, so what do you mean by mongoloid slant? Mongoloid slant, upslanting palpebral fissures. So what do you mean by upslanting palpebral fissures? Generally, if you draw a line, okay, from the inner canthus to the outer canthus, this will be a straight line. Okay, the outer canthus and the inner canthus will actually meet at an exact straight line. Yes or no? That is normal. But if you see what's happening here, see this eye. If I'm drawing a straight line from the inner canthus, see the outer canthus where it is located. It is located above the line which I'm drawing, which means the eyes are slanted up like this. This is what we refer to as what? Mongolian slant, or otherwise called as upslanting palpebral fissure. That's the definition of Mongolian slant. That's the definition of upslanting palpebral fissure. And here is another example of upslanting palpebral fissure. This is also an example of the same. You can see here pretty clearly, like if you draw a straight line, definitely your outer canthus is what? Above the line that is drawn from the inner canthae. So definitely the eyes are what? Slanted up. So this is an example of upslanting palpebral fissure, or otherwise called as Mongolian slant. But even though this child is having hypotelorism, you can see that inner and outer canthae are meeting at a straight line, which means this child is actually not having Mongolian slant. So it doesn't mean that all these features should be present in the same person. Yes or no? Okay, this is an example of low posterior hairline. The hairline will come in this situation, it is coming very close to the C7 spine. So you can see it is the C7 spine here, and the hairline is actually close to the C7 spine. So this is called as low posterior hairline. Very commonly seen in patients who are having short neck. If the neck length itself is short, means the hairline will come down automatically. What is the classic example of a short neck? Klippel-Feil anomaly. Have you heard about that? Klippel-Feil syndrome, where there will be fusion of one or more cervical vertebra. Have you heard about that? Klippel-Feil anomaly, Klippel-Feil syndrome, which is one of the characteristic example of short neck, because in Klippel-Feil syndrome there will be fusion of one or more cervical vertebra. What else is there? Okay. Now I think let us move on to some of the causes, because once you say about hypertelorism or hypotelorism or short neck or whatever it is, they'll be asking you list out some of the causes. So where you will see hypertelorism, list out some of the causes where you will see hypotelorism, and list out some of the causes where you're going to see low posterior hairline. List out some of the causes where you're going to see short neck. Okay, I didn't talk about short neck, isn't it? So that itself will be the definition of short neck. I didn't tell about that. So short neck is also an important marker of congenital heart disease. How to tell whether the patient is having short neck or not? We use something called Bird index. That's called Bird index. What do you mean by Bird index? You're going to take the entire patient's height in centimeters or meters, whatever, divided by length of anatomical neck. I told you what is anatomical neck already. What is anatomical neck? From the external occipital protuberance to the C7 spine. So if you take this ratio, this is what we call as Bird index. Normally, this should be less than 12.8. Okay, which means if the neck is of sufficient length, this ratio will be less than 12.8. If it is more than 13.6, it is considered to be abnormal and it is suggestive of short neck. As the neck becomes smaller and smaller, the Bird index will keep increasing. Yes or no? So if this index is more than 13.6, it is considered to be short neck. So if they ask you how to find out Bird index, I mean, how to find out short neck? You have to answer bird index. More than 13.6 is considered to be short neck. Okay, so we discussed this and we have some causes. Okay, so now what are the causes of hypertelorism? List out some of the few causes. I'll finish it here itself. Hypertelorism, where will you see it? Usually, hypertelorism is a feature of craniosynostosis syndromes. Craniosynostosis. I'll talk about those syndromes in a while. It needs just 10-15 minutes to discuss. So, craniosynostosis syndromes. What are the basic craniosynostosis syndromes? We have Eppert syndrome, we have Cruzen syndrome, and we have Pfeiffer syndrome, as I told you. So remember, all these craniosynostosis syndrome, as I told you in the beginning itself, they are autosomal dominant inheritance and they are related to mutations of a gene called FGFR2, fibroblast growth factor receptor. Sometime back only I told you, right? The FGFR2 mutations. So Eppert, Cruzen, Pfeiffer, all these are autosomal dominant and related to FGFR2 mutations. Three important syndromes are there: Eppert, Cruzen, and Pfeiffer syndrome. So whenever you say craniosynostosis, definitely, like they will ask you what are the characteristic features, especially when you're going, I mean, medicine, I'm not sure, they will ask only the syndromes, but in pediatrics, definitely they will ask you the actual features of these syndromes. What are the features of these syndromes? Eppert, Cruzen, and Pfeiffer. So all these syndromes will have a triad. Some triad of features, but some differences will be there, I'll tell you that. But all these may have certain specific triad. First thing is craniosynostosis, of course. That's the reason why they are called as craniosynostosis syndromes. First feature is craniosynostosis. So what do you mean by the term craniosynostosis? Multiple sutures will be fused. Okay, plagiocephaly. Multiple sutures are fused. So that's why we call, that's the actual idea of craniosynostosis. Okay, and because of craniosynostosis, multiple sutures are fused prematurely and abnormally. There will not be any significant room for brain development. The brain development can be lesser. Okay, the brain development can be reduced and the brain development can be lesser. So because the brain development is reduced, you can end up with something called as mental retardation. Okay, mental retardation. So MR is common. Mental retardation is quite common. So where you won't get mental retardation? Which syndrome is the only exception? Exception is Cruzen syndrome. Exception is Cruzen. So how you can remember that Cruzen will have normal IQ? They don't have MR. So Cruzen syndrome patients can crack exams. Okay, so that's how I used to remember during my UG time, because in our pediatric exams and all, like they torture us with syndromes, completely with syndrome. Cardiology, neurology, everywhere they ask syndromes only. I don't know, they are very, very fuzzy about syndromes. So they will ask, so we are in a position to learn this definitely. So Cruzen crack exams. That is the, like mnemonic to remember that Cruzen will not have MR. Second feature is maxillary hypoplasia. And again, because of craniosynostosis only. Many patients will have maxillary hypoplasia. And because of that, there might be significant dental malocclusion. And again, this is related to the premature closure of sutures only. There will be dental malocclusion and there will be significant teeth loss, early teeth loss. There is always a proverb, isn't it? In Bible also they used to say, if one door opens only, other door closes. One door closes only, other door will open. There is a famous sentence from Bible. Like that, unfortunately, Cruzen syndrome patients, even though they have normal IQ, another door closes in the form of maxillary hypoplasia. Their dentition will be extremely poor and they will lose teeth much early. Okay, that's one problem with them. This can be seen in anything, but Cruzen specifically will have significant maxillary hypoplasia and early teeth loss, dental malocclusion. And third thing is going to be your hand and feet problems. Hand and feet problems. So Eppert syndrome will have syndactyly. Cruzen syndrome, hand and feet will be normal. Okay, there won't be any problem. So again, if somebody wants to crack exam, if their hand and feet are abnormal, how can you crack exam? Yes or no? Correct or wrong? Okay. So that's why Cruzen, that's why I told you, in Cruzen, one door is open, but other door closes in the form of what? Yeah. So Cruzen can only crack exams, but not Viva OC. Okay. Because there will be significant maxillary hypoplasia and there will be early teeth loss. Okay. Then we have Pfeiffer syndrome. In Pfeiffer syndrome, there will be brachydactyly. Brachydactyly, and probably we can say ulnar deviation of thumb. Okay, Pfeiffer will have brachydactyly, whereas Eppert will have syndactyly. It's easily understandable because hand and feet problems will be there in Eppert and Pfeiffer. Again, why? Because I told you they are having MR. What's the fun in having nice hand and feet if they can't write any exam with mental retardation? So they will have hand and feet problems, brachydactyly and syndactyly. Okay, this is the typical triad. And apart from that, they will have hypertelorism, as we know that. That is again because of premature closure of sutures only, and they might have strabismus. You know what is strabismus, isn't it? Yeah, squint. That is strabismus. Again, because of premature closure of sutures and abnormal shape of the skull. That's why they have all these problems. Okay. So what else can cause hypertelorism? Apart from craniosynostose syndrome, it is Noonan syndrome. I'll talk about Noonan's in a while. Noonan syndrome is also called as male Turner's by Indian examiners very commonly, but that name should be avoided because it's a completely different syndrome. I'll talk about that. But Noonan syndrome also can result in significant hypertelorism. What are the conditions that produces hypotelorism? Few examples of hypotelorism. One is Fragile X syndrome. Fragile X syndrome. You know what is the problem in Fragile X syndrome? It is due to FMR1 gene mutation. It is obviously, as the name implies, it is present in X chromosome. It's not in the autosomes, it is in the sex chromosomes. FMR1 gene. The gene stands for Fragile X mental retardation gene. FMR1 gene. That is the gene that is defective, and as we all know, it's an X-linked disorder, or inheritance is X-linked, and it's a trinucleotide repeat disorder. So what is the repeats that you encounter here? CGG repeats. You all know that. I mean, this is very common, isn't it? CAG for Huntington's disease, CGG for Fragile X, CAG for myotonic dystrophy. These are quite common, isn't it? And CTG for what? CTG for myotonic dystrophy, man. CAG for Huntington's disease. CGG for Fragile X syndrome. And GAA for Friedreich ataxia. Have you heard of this? These are the four things that they will commonly ask in exam. Once again, I'll repeat. CAG, Huntington's disease. CTG is myotonic dystrophy, especially type 1. CGG is for Fragile X syndrome, FXS. And GAA is for Friedreich ataxia. Okay, these are important trinucleotide repeat disorders. And what are the features of Fragile X syndrome? They'll have large ears. Okay, everything will be big except the testes. I'll talk about that in a while. Everything will be big except testes, which will be small. Okay, big ears, number one. Then big face, long face. Rather than calling big face, you can call long face. They will have big forehead, large forehead, sometimes frontal bossing also. sorry, they will have big testes also, macroorchidism, huge testes, but small IQ, MR. That's why the gene itself is called as what? Fragile X mental retardation gene, FMR1 gene. So big ears, big long face, big forehead, big testes, that is macroorchidism, but a small IQ. MR will be there. So this is a typical feature of Fragile X syndrome. Then we have another one, fetal alcohol syndrome. Fetal alcohol syndrome is a very, very important topic. Again, see, in exam, especially if you go to pediatric exam, fetal alcohol syndrome, fetal Hydantoin syndrome, and fetal warfarin syndrome. These three things you should never forget. Okay, these three fetal syndrome. There are many things given in pediatric textbooks, but fetal alcohol, fetal warfarin, and fetal Hydantoin. So all these are very important topics. Okay, so what are the features of fetal alcohol syndrome? Number one, DD. Whenever in pediatrics you call DD, what is that? Developmental delay. It's not differential diagnosis. Okay, developmental delay, very common. Then stunted growth. Then cardiac anomalies will be there. Cardiac illness, very commonly, it could be a ASD or a VSD. Then patients tend to have microcephaly, small head. As we are discussing in the topic, they will have hypotelorism, not hypertelorism. And they can have epicanthal folds. I'll show you the epicanthal folds in a while. And they will have, how to say, philtrum will not be seen properly. Indistinct philtrum. Okay, fine. I think so. So what do you mean by that? How to explain that? You know what is philtrum, right? So you have this typical philtrum in the lips. Maybe you can assume it's not prominent. Okay, it will not be seen properly. It will look like straight lips. You will not be able to categorize that philtrum properly in these patients. Or indistinct or not so prominent philtrum. Then they will have a thin lip, especially upper lip. Upper lip. And they will have camptodactyly and clinodactyly. So what do you mean by the term syndactyly? Everyone knows. Fused digits is syndactyly. What do you mean by polydactyly? Extra digits is polydactyly. What do you mean by brachydactyly? Short digits is brachydactyly. What do you mean by camptodactyly? Camptodactyly and clinodactyly, the name itself says it starts with what? C. So curved fingers. Curved fingers is campto and clinodactyly. Fingers will be curved. So now both are curved fingers. Where it will be curved? Camptodactyly. You have CAM. Okay, camptodactyly. CAMP. Both A and P is there in camptodactyly. So AP curvature. Anteroposterior curvature. So the curvature will be like this. Okay, in the anteroposterior direction. Do you have AP in clinodactyly? No. In clinodactyly, where you have A and P? You don't have A and P. So clinodactyly is not AP curvature, whereas clinodactyly has L in it. So it's a lateral curvature. Yes or no? Camptodactyly is anteroposterior curvature. Clinodactyly is lateral curvature. Like this, the fingers may be curved. Clinodactyly. So for example, very common clinodactyly we see in pediatric patients with anomalies is the little finger will be curved towards the ring finger. Okay, the fifth finger will be curved towards the fourth finger. That is the commonest abnormality we see. That's a type of clinodactyly only. Lateral curvature. Okay, then we talked about low hairline and short neck, because whenever there is a short neck, there will be low posterior hairline. So both can be viewed as a single entity. Okay, because whenever you have a short neck, you are going to have what? Low posterior hairline. So what are the conditions that produce short neck and low posterior hairline? Of course, first one I told you very carefully. What is that? So many times I told you. What is that? Klippel field anomaly. Second condition that can produce short neck and low posterior hairline is Noonan syndrome. And the third one is Turner syndrome. So these are three important syndromes that tend to produce short neck and low posterior hairline. So in the Klippel field anomaly, okay, in the Klippel field anomaly, we'll have a characteristic triad. So that is called as craniovertebral fusion. So what do you mean by craniovertebral fusion? As I told you, one or more cervical vertebra can be fused with each other. That's why you get that short neck. So craniovertebral fusion. Based on this, you have multiple different types of Klippel field. So you have KF1, KF2, and KF3. So KF1 and KF3 are autosomal recessive, whereas KF2 is autosomal dominant. Generally, the fusion will be C1 and C2, atlas and axis. In case of KF1, it will be C2 and C3. In case of KF2, except C1 and C2, if anything else is fused, that is called as KF3. Short neck. You have three types of Klippel field: 1, 2, and 3. 1 and 3 are autosomal recessive, 2 is dominant. And C1, C2 fuse means that is 1. 2 and 3 fuse means that is 2. Anything apart from C1 and C2, if it's fused, means that is KF3. So there will be craniovertebral fusion. That is the reason why you are getting short neck in the first place. Next, obviously, because we are discussing under short neck, the second feature of Klippel field is short neck, of course. And associated feature of short neck is what? Low posterior hairline. This is a very associated feature of short neck. Then apart from that, patients will have multiple other anomalies. So what are the multiple anomalies the patient can have? They can have CVS anomalies, which is very commonly a VSD, or they can have scoliosis, spine abnormality. Again, that is because of the abnormal development of the spine only, because of craniovertebral fusion. And they can have eye and ear problems in the form of deafness and blindness. Okay. Typically, eye problem will be colobomas. You know colobomas, isn't it? One part of the iris may not be there at all. Okay, it will not be developed at all. So there, it looks like as if there is a hole in the iris. So that is colobomas. Then ear abnormalities also can be there, which is typically a conductive deafness, because the bones may not be developed properly that transmit the sound to the cochlea, may not be developed properly. The middle ear may not develop properly, may fuse, so resulting in conductive deafness. These are extremely common. So these are the characteristic features of Klippel field anomaly. Apart from that, we missed out on a lot of other congenital markers, congenital heart disease markers. What are they? Widely spaced nipples. Have you heard about that? Which is very commonly seen in what? Turner syndrome. Then apart from that, we do have other things like upper segment, lower segment ratio. We do have arm span. Then we do have metacarpal index. So these are things that we need to discuss maybe after the break. Okay, and we are going to discuss a lot of syndromes: Marfan, Turner's, Noonan's, Down's, then Ellis Van Creveld syndrome. Then we have charge anomaly. Then we have DiGeorge syndrome. So these are syndromes, at least some 10 to 12 syndromes are there. At least that you need to know for exams. Okay, other things is not important, but at least some 10 to 12 is there. Important. And when you go to neurology exam, the most important syndrome or probably malformation that you need to know is Arnold-Chiari malformation. Never go to the exam without knowing Arnold-Chiari malformation. Very commonly asked question. Okay, so because most of the posterior circulation symptoms are caused by Arnold-Chiari malformation. So if the examiner wants to torture you, especially when you are dealing with a brainstem stroke, when they ask about the DDs for brainstem stroke, one of the most important DD is Arnold-Chiari malformation. So if you get stuck into that, you will not be able to come out. So the idea in exam is to just quickly come out of some topic they ask. That is the idea. Even if you are very confident in a particular topic, never indulge in that topic for a very long time. Your idea is to push the examiner, keep pushing the examiner to multiple different topics that you know. That is an art actually. So you should never indulge into one topic continuously. That's always a sign of danger. Okay, you'll learn with time actually. Especially Indian exams, it's an art actually. How to move that. Okay, now you can go for lunch. I think 3 o'clock you can come back. Okay, only one thing, the definition of something called telecanthus is what I forgot. So we have discussed about hypertelorism. We have discussed about hypotelorism. But there is another thing called telecanthus. I don't know where is that. So definition we discussed. Yeah, it's here. Only one more definition is there, that is telecanthus. So telecanthus is a completely different abnormality of the eyes where there will be increased inner canthal distance. The inner canthal distance will be increased, but your interpupillary distance will be normal. That is what we call it as telecanthus. So here is where I'm writing. Your inner canthal distance will be increased, but your interpupillary distance will be normal. That is telecanthus. For example, how to objectify it, how to learn objective fashion, we have something called mustard ratio. That ratio is called mustard ratio. What is mustard ratio? You're going to take ICD by IPD ratio. Of course, you know that the inner canthal distance will be high, but interpupillary distance will be normal. So this ratio will be more than 55% or 0.55. And this is what we refer to as mustard ratio. So whenever your ICD by IPD is more than 0.55, you can diagnose telecanthus. And the image that I showed you in the beginning for Mongolian slant is there. So in this guy, you have a right telecanthus actually. As you can see here, the inner canthal distance will be very high in this guy, but your interpupillary distance will be relatively normal, will be spared. Okay, so this guy, even easily if you want to know, so if you see the distance between the inner canthus of left eye and the right eye, you can see a little bit of asymmetry on the right side. Can you see that in the right side, the inner canthus is slightly like separated more than what is on the left side from the midline? Can you see that? So this is telecanthus. This child is actually having a right-sided telecanthus. So this is what we call telecanthus actually. Hypertelorism means the both side inner canthi will be what? Separate out and the entire orbit itself will be moving out. So that is hypertelorism. So here only the inner canthi will be a little outside, little lateral, but the pupillary distance will be relatively normal. Okay, then coming to some of the key syndromes, important syndromes, the most important for any person who's attending clinical exam, maybe a PG or maybe UG, doesn't matter. The Marfan syndrome is extremely important. You cannot go to the exam without knowing Marfan syndrome. Even as an adult, it's one of the very, very important syndromes. So what are the features of Marfan syndrome? I'll show the pictures of Marfan's later on, but what are the features of Marfan syndrome in the first place? First of all, it is due to fibrillin 1 gene mutation, as we all know, and it's an autosomal dominant condition. So what is the function of fibrillin 1? Fibrillin 1 actually forms a scaffold for the attachment of elastic fibers. You have elastic fibers in our body, right? So these elastic fibers have to get attached to something, and this fibrillin 1 protein serves as a scaffolding for attachment of this elastic fibers. So where the elastic fibers are maximally present? Skin, common example. Then blood vessels, lung, super examples, because blood vessels have to expand, especially arteries. So they should be elastic. Your lung should be recoiling back, so they should be elastic. And your skin should be, of course, elastic, because to allow the mobility of the limbs. Otherwise, you can easily stretch the skin and bring back the skin in one place, because you need that extra mobility. So if skin is very stiff, you will not be able to be mobile. The best example is scleroderma. Or patients are having something called diabetic chiroarthropathy. So what happens in these guys? In scleroderma, there will be very thick skin. So they will not be able to flex at all because the fibros of the skin. So they will not be able to do like this. This is called what? Prayer sign. So they will not be able to do this symbol. They cannot do that because of the stiffness of the skin. That's called prayer sign. Prayer sign generally is positive in two important conditions. One is scleroderma. Second is diabetic cheiroarthropathy. Okay, even very long-standing diabetes patients also, you might experience that prayer sign, and that is again because of the thickening of the skin, because of long-standing diabetes itself. That's called diabetic cheiroarthropathy. Okay, fine. So that's why I'm telling the importance of elastic fibers, elasticity of the skin. That's why it's there. And these elastic fibers are also present, and this fibrillin proteins are also important in the eyes, especially in the zonules of the lens. So that's why lens dislocation is very commonly seen in patients with Marfan syndrome. All these are extremely important. So pathophysiology wise, whenever fibrillin 1 is mutated, and if it's dysfunctional, you will not have support for these elastic fibers, right? There will be disintegration of these elastic fibers, and there will be a loss of support by microfibrils also. And fibrillin 1 generally binds to TGF beta. The other function of fibrillin 1 is it has to bind with TGF beta, transformation growth factor beta. So if fibrillin 1 is defective, you will have increased TGF beta levels as well. And this is thought to activate matrix metalloproteinases, which lyses the matrix in many areas, and that has thought to be one of the reasons for the complications that we've seen in patients with Marfan syndrome. In summary, what you can say, loss of support to the elastic fibers are lost, plus your support to the lens zonules. The zonules of the lens is lost. Number 3, your attachment with TGF beta reduces because of that your TGF beta levels increases, free TGF beta, and that is going to activate matrix metalloproteinases, which can resolve in the dissolution of the matrix in different areas, resulting in other problems of Marfan syndrome. So I don't want you to bore with a lot of features of Marfan syndrome, even though that's important. But let me tell you, how will you diagnose Marfan syndrome? Marfan syndrome is basically diagnosed with something called as revised Ghent criteria. So originally Ghent proposed a diagnostic criteria, but currently it's revised a little bit, called as revised Ghent criteria. So based on revised Ghent criteria, how will you make a diagnosis? Remember, if you study in books, it will be very tough. I'll tell you in a very easy manner. So there are 3 important features of Marfan syndrome. One is aortic root dilatation. Second is ectopia lentis. Okay, that is lens dislocation. Third is systemic features. I'll talk about systemic features in a while. I'll finish in 5 minutes, don't worry. Systemic features of Marfan. And then you have fibrillin 1 gene mutation. These are the 4 important things as far as Marfan is concerned. These are the 4 cornerstones for diagnosing Marfan based on revised Ghent criteria. So to be honest, you yourself tell me, if the patient is having a family history, suppose the patient has family history of Marfan syndrome, clear-cut family history of Marfan syndrome, then do you need to test fibrillin 1 gene mutation? Yes or no? Do you need to test for that? Answer is no, because that family history itself is like a test of fibrillin 1 gene mutation positivity. So you need not test for fibrillin 1 gene mutation. So what you all need? Any one of these 3. Am I right or wrong? So there is no need to test for fibrillin 1 gene mutation. In the presence of family history, any one of aortic dilatation or ectopia lentis or systemic features is more than enough. Suppose if you do not have family history, that is where the confusion is. If you don't have family history, then you need combination. So you cannot diagnose just with one of the features in the absence of family history. If you don't have family history, you may need to have some combinations. So either you need a combination of aortic root dilatation and ectopia lentis, or you need to have a aortic root dilatation with systemic features, or you need to have a aortic root dilatation with fibrillin 1 gene mutation. Do you understand? Simple, isn't it? Which means aortic root dilatation is must. Along with that, you should have either ectopia lentis, or you should have systemic features, or you should have fibrillin 1 gene mutation. One more addition that they have made in the recent revised, this was the original Ghent criteria. One more addition that they have made in the revised Ghent criteria is, even if you have ectopia lentis along with fibrillin 1 gene mutation, you can make a diagnosis. That's the addition they have made. Apart from that, in the original Ghent criteria, what they have said is, if you have aortic root dilatation plus any one of either ectopia lentis or systemic features or fibrillin 1 gene mutation is enough. But in the latest revision, they have added that in some patients, you can just have ectopia lentis alone without any of the other features. So even with ectopia lentis and fibrillin 1 gene mutation, you can make a diagnosis of Marfan syndrome. So it's actually quite simple. In the absence of family history, you definitely need a combination. Just one feature will not be sufficient to diagnose Marfan in the absence of family history. So combination is what? Aortic root dilatation plus any one of the remaining three features, okay, as I've told you, or second is ectopia lentis plus fibrillin 1 gene mutation. Okay, just remember these two. This is more than enough. I cannot say Ghent criteria easier than this. Okay, these are the four cornerstones. Presence of family history, any one of the remaining three without fibrillin gene mutation is enough. In the absence of family history, aortic root dilatation plus any one of the remaining three, or ectopia lentis plus fibrillin 1 will tell you it's a Marfan syndrome. Here the confusion will happen for the systemic features only, because examiner is not going to ask about aortic root dilatation. Examiner is not going to ask you about ectopia lentis. Examiner will ask you about systemic features only. So there is a separate score called as systemic scoring. So systemic scoring for Marfan syndrome is actually quite important. At least the features, some of the features in the systemic scoring is important. So what are the features you have? One of the important features is called as wrist sign or thumb sign. Wrist sign and thumb sign. Remember, if only one is there, then your score will be 1. If both is there, score will be 3. You are going to give a score of 3. If both are there, then significance is very high. Wrist sign and thumb sign. So what do you mean by the term wrist sign and thumb sign? Everyone will be knowing that. I think I don't want to explain much about this. What is wrist sign and thumb sign? Here it is. This is what we call as wrist sign. So what you need to do is, you have to make a ring with your thumb and the little finger. With the pinky and the thumb, you have to make a form a ring here at the level of the radial styloid in the wrist. Remember, at the level of radial styloid in the wrist, you have to make a ring with the help of a thumb and the little finger. So normally, for most people, like the overlap will not happen. You will not be able to overlap your thumb above the ring finger or ring finger above the thumb. That overlap will not happen most of the times. If your overlap happens, that is wrist sign. When it is significant, if the overlap happens, plus if the overlap is crossing the proximal nail border, then it becomes very significant. Okay, so this is wrist sign. As you can see, in this situation, as you can see here, in this finger, in the small finger, as you can see here, it is overlapping the proximal nail border. Can you see that in this example? So if it overlaps the proximal nail border of one of the fingers, then it becomes very significant, because some people may have a small overlap maybe there, which is quite normal, especially very thin individuals. It is common. But if it overlaps the proximal nail fold itself, then it becomes very significant. That is wrist sign. This is thumb sign. So what you need to do is, you have to create a fist with your thumb inside the palm and make a fist. Normally, thumb will be nicely residing inside. But if your thumb moves outside the ulnar border, okay, this is the ulnar border, right? So if the thumb moves outside the ulnar border of the palm, that becomes quite specific for Marfan syndrome, or it can happen sometimes in homocystinuria also, but Marfan syndrome, okay, wrist sign. This is called as thumb sign. Because some notorious examiners will ask you to demonstrate the wrist sign and thumb sign in your exam. Okay, second, what are the other problems? Pectus carinatum and pectus excavatum. Which is more specific for Marfan, pectus carinatum or excavatum? Carinatum. Because carinatum carries 2 points, but excavatum carries 1 point. What is carinatum? It's called as pigeon chest or pigeon breast, where there will be a protrusion, abnormal protrusion in the chest. Excavatum is an abnormal depression in the chest. Okay, excavatum is abnormal depression. Carinatum is abnormal protrusion. Carinatum is more specific for Marfan compared to excavatum, and they can have foot deformities like hind foot deformity is quite common, which carries 2 points, whereas there is another problem called as flat foot, that is called as pes planus. Pes planus, that is called as flat foot. So it's actually quite easy to find out pes planus and pes cavus. Ask, I have the shoes, otherwise I would have shown myself. Ask the patient to stand, anyone, normal person to stand. When they stand, the lateral border of the foot will touch the ground generally, but the medial border will not touch usually. If both the lateral medial border does not touch, it is pes cavus. If both the borders touch, it is pes planus. That's all. Do you understand? Fine. Pes planus carries 1 point, that is flat foot. Then you have pneumothorax, common in these patients because again bulla formation is common because elastic fibers lost support. In emphysema, because of elastic issue only you get bulla. Same thing here, because of loss of elastic fibers, support elastic fibers, you might result in bulla in the lungs, which can result in pneumothorax. And one of the very specific features is dural ectasia. We can call it as, at your level, I can say redundant dura, extra thickening of the dura mater, so called dural ectasias. Okay, very thick redundant dura. There is something called protrusio acetabular, which carries another 2 points. And 7th is reduced upper segment lower segment ratio. Okay, reduced upper segment lower segment ratio, and simultaneous increased arm span by height ratio. Arm span by height ratio. Okay, this carries 1 point both together. So first of all, you need to know what is upper segment lower segment ratio. Generally, upper segment divided by lower segment will be more than 1. Okay, if the age is less than 10 years. By around 10-year mark, it will be equal to 1. But beyond puberty, definitely upper segment lower segment ratio will be less than 1 after 10 years of age. Beyond 10 years of age, definitely the ratio will become less than 1. It will not be more than 1, which means normally itself for most of us, your lower segment will be relatively more than the upper segment. This is quite normal for most of us. Approximate ratio in adults will be 0.9. Okay, 0.9:1. Approximately, it will be 0.9, somewhere around 0.9, but will not be very less also. In Marfan syndrome, what will happen is there will be abnormally elevated lower segment. Lower segment will be too bigger compared to upper segment. So in Marfan syndrome, usually the ratio will be less than 0.85. Generally, in Marfan syndrome, the ratio will be less than 0.85. Some books will give you less than 0.9 also. It doesn't matter. Okay, but approximately somewhere around 0.9 is the normal. Anything less than 0.9, or if you want to be more specific, less than 0.85 will be suggestive of more abnormally enlarged lower segment, and that is feature of Marfan. And arm span by height, this is also very important. So remember, generally arm span will be lesser than the height in younger age. As you reach adulthood, arm span will become more than that of the height. Around puberty, your arm span by height will become almost equal, but beyond puberty, arm span and height will be disproportional. Arm span will become more. So generally, what will be the normal arm span and height difference? Usually it's approximately plus 1 centimeter in females and up to plus 4 centimeter in males. Generally in Marfan syndrome, it will be more than 4 centimeter. It will be negative value before puberty. Generally, arm span will be lesser than that of the height, but as the age progresses, generally arm span becomes more than height. So the difference will become positive. Up to plus 4 in males is normal, or anyone is normal. So if it becomes beyond 4 centimeter, then it's an even more arm span. That is because of the slender fingers, elongated slender fingers, the arm span will increase basically. And because that, it might be more. Similarly, there is a ratio called arm span by height ratio also. So some books give, if it's more than 1.04, we can call it as abnormal. So if you want to call it in the form of ratio, it is 1.04. If it's more than 1.04, it is supposed to be abnormal. Arm span by height ratio. Again, this is a very important point in exam. And number 8, patients may have scoliosis or kyphosis. That's why in the beginning she said kyphoscoliosis as a marker of congenital heart disease, but it is not widely regarded as a marker of congenital heart disease because Marfan syndrome is not associated with congenital heart disease. So that is how the examiner catches you in exam, because Marfan syndrome is associated with aortic regurgitation later in life. It is not associated with the congenital heart defect, isn't it? That's why you should not say that as a marker of congenital heart disease, which is very important. So because it's a common tendency for students, because it's a syndrome, right? So whenever we talk about syndrome, we always think about congenital heart disease. So that's a common mistake you do. Marfan doesn't produce any VSD or ASD or any type of congenital heart disease. It produces AR or MVP, MR. These are all coming later in the life. Then patients can have reduced elbow extension, restricted elbow extension, which is very common, which carries another 1 point. And there are certain facial features. Typical Marfan's face will be there. There are 5 facial features that's been described. If at least 3 out of 5 is there, that carries 1 point. What are the 5 important Marfan features? One, I told you so many times, dolichocephaly. Didn't I tell you? From the beginning, I was telling dolichocephaly, straight face, long face. Then the patient will have small palpable fissure, enophthalmos. Big palpable fissure is exophthalmos. Small palpable fissure is enophthalmos. Then I told you about Mongolian slant that happens in Down syndrome, upslanting palpable fissures. But Marfan syndrome patients can have down slanting palpable fissures. So same thing, same definition, but instead of the outer canthi being up than the inner canthus, in this patient, the outer canthi will be down compared to the inner canthus. That's called down slanting palpable fissures. And many patients will have retrognathia. What is retrognathia? Small chin. It will be receding inside. That's called retrognathia. Last but not the least, there is something called malar hypoplasia. They will not have prominent malar component. So there will be malar hypoplasia. Out of 5, if you have at least 3, that carries 1 point. Many patients will have skin striae. This is a skin feature. And again, skin striae is due to loss of elastic support on the skin. Because of loss of elastic fiber support on the skin goes for striations. That why you get that striae in pregnancy and all, stretch marks. That's because of too much of stretch, the elasticity is lost. That's why you get stretch marks. Same thing happens here. Loss of elastic support, skin stretch marks are extremely common. That's what we call skin striae. And number 12, myopia. That is because of dolichocephaly itself. People who are having dolichocephaly are at the risk of developing myopia. But if it's more than 3 diopters only, it will be coming under classification. Systemic scoring. Otherwise, it will not be included under systemic scoring. At least 3 diopters and above should be there. Number 13, mitral valve prolapse carries 1 point. MVP is the most common valvular heart disease associated with Marfan syndrome. So you have 13 features, each and everything has scoring system. If it's 7 or 7, I mean score is at least 7 and above. I told you, that's why I told you the scoring system. If at least 7 and above is there, then probably you can make a diagnosis of Marfan syndrome. Suppose if the score is less than or equal to 4, systemic features, score is less than or equal to 4, then it is actually called as non-specific connective tissue disease nomenclature. If things are there, but it's not fitting into Marfan means non-specific connective tissue disease. The score is 5 to 6, then it is called as MAS syndrome. It's called as MAS, not Marfan. So which means we call Marfanite features, right? Where the patient may not have syndrome, but some features may be there. That's called as MAS syndrome. So what do you mean by MAS syndrome? MAS stands for myopia MVP and mild aortic dilatation. A stands for aorta, aortic dilatation, and skin and skeletal syndrome, which means they will have something, okay, like Marfan syndrome. Features very similar to Marfan syndrome, but the score will not reach that 7 mark. More than or equal to 7, we are going to call it as what? Marfan syndrome. Suppose if the patient is having less than or equal to 4, plus if the patient is having mitral valve prolapse, this is the definition of mitral valve prolapse syndrome. So what is the other name for mitral valve prolapse syndrome? Barlow syndrome. Very common question in the exams again. BRLOW. Mitral valve prolapse syndrome is otherwise called as Barlow syndrome. See, everything is objectified. Okay, nothing is not objectified. That's what you need to know. For everything, you have a reason. You have objectification of that. Even though it might be not so interesting, it doesn't matter. You need to objectify things. Without objectification, it doesn't work just by visualization. We are living in the era of modern medicine. We need objectification and quantification of each and everything. So these are the definitions of Marfan's, MAS, and MVPS, and so on. Okay, right. What is the most important therapy for Marfan? Beta blockers. And what is the most important problem, life-threatening problem in Marfan? That aortic root dilatation. That is the life-threatening problem, basically, because they can go for aneurysmal dilatation, and they can, because of the loss of elastic support, and elastin will not be there, so they can dilate, and they can rupture one day. That is one of the life-threatening problem, aortic aneurysms. So that is why one of the important treatment options is surgery. Surgery. So when you will do surgery? Whenever aortic diameter is more than 5 centimeter. Whenever aortic diameter is more than 5 centimeter, you have to do surgery. Or alternatively, you can do at less than 5 centimeter itself, plus if the patient is having any one of progressive AR or family history of aortic dissection or rupture. If there is a family history of somebody died because of aortic dissection or rupture, if the aneurysm is exhibiting rapid growth of at least 5 millimeter per year, 5 millimeter per year, okay, rapid growth, 5 millimeter per year means 0.05 centimeter per year, okay. Sorry, 0.5 centimeters a year. Rapid growth, either 5 millimeter per year or 0.5 centimeters a year. Okay, so if any one of these three things are there, then probably you can consider surgery even if the aortic diameter is less than 5 centimeter on echocardiogram. Medical therapy. The most important two arms of medical therapy are beta blockers and AC inhibitors. Beta blockers and AC inhibitors. Of course, beta blockers is going to reduce the force of contraction, as well as it's going to reduce the heart rate. Please understand, simple logic, leave all the other laws of physics and everything. So if you have something, if you keep ejecting more and more, the aneurysmal dilatation will increase. Or if you reduce the force of ejection, aneurysmal size will decrease. If you reduce the force of ejection and if you reduce the heart rate, number of contractions, aortic and aneurysmal dilatation can be reduced. Simple rule, that's all. That's why we use beta blockers, which can actually reduce the progression of aortic dilatation. That's why we use beta blockers. Second is AC inhibitors. Interestingly, angiotensin receptor blockers were not found to be beneficial in patients with Marfan syndrome. This is a very interesting thing. Only AC inhibitors has been found to be beneficial. The reason is because angiotensin 2 can upregulate TGF beta. Okay, can upregulate the TGF beta levels. This is a well-known scientific point. Angiotensin 2 can upregulate the TGF beta. If you give angiotensin receptor blocker, understand that it's going to work only on the angiotensin receptor. It is not going to have any effect on the angiotensin 2 itself. Do you understand or not? But whereas if you give AC inhibitor, it reduces the levels of angiotensin 2 itself. That is why it can downregulate the TGF beta production. And that is the reason why initially itself I said this fibrillin 1 binds with what? TGF beta, and this excessive TGF beta is one of the main reasons for some of the, in fact, many of the features of Marfan syndrome. I mean, whatever I tell has some reason. That's why it is. So that's why we follow these two important medical therapy, that is TGF beta, I mean, angiotensin converting enzyme inhibitors and beta blockers. Surgery, when should be done? This should be in fingertip for any postgraduate who attends the exam. Okay, never ever ignore this. This is very, very important. Important syndromes, Marfan. So do you have anything else? Yeah, one more thing. So this is a high arch palate. It's not under the systemic feature criteria, but still very common feature of Marfan. That is because of dolichocephaly itself. Long face, I told you, sometime back in long face, you'll have a narrow and a deeper arch, palatal arch. And if it becomes more deeper, you can get a high arched palate. So what is high arch palate? It's just a very narrow and a very deep arch. That's called high arch palate. As you can see, it's very deeper. You can see like it's opening like a pit actually inside. And another one is called metacarpal index is there. This is another one. This is called as metacarpal index. So what is metacarpal index? You are going to take the 4 metacarpals. Usually, generally, we ignore the thumb in most calculations. So 4 metacarpals, 2, 3, 4, 5, 4 metacarpals. And we are going to add the length, okay? Add the length of all the 4 metacarpals. So maybe I can say the length of all 4 metacarpals can be given as A, B, C, and D. And also I'm going to look at the width of all 4 metacarpals. Okay, I can write it as small a, small b, small c, and small d. Okay, width of all metacarpals. As it's given here, you can see metacarpal index is nothing but adding all the length divided by adding all the width of all metacarpals. Okay, that's why capital A, B, C, D divided by small a, B, C, D. This is what we call as metacarpal index. Normally, metacarpal index should be less than 8.4. Okay, anything more than 8.4 is considered to be abnormal. So what does that indicate? If it's more than 8.4 means if the ratio is high means what does it indicate? The patients are having abnormally long metacarpals than the width of the metacarpals. So that tells you that this patient is having arachnodactyly. So what is arachnodactyly? Thin, slender fingers. You saw spider fingers. How spider fingers are? I mean, spider doesn't have fingers. Spider legs are. How spider legs are there? It's very thin but long, isn't it? These patients will have a very long and slender fingers. That kind of long and slender fingers, thin fingers is what we call arachnodactyly. So to find out that only we are using this. What is this? Metacarpal index. More than 8.4 is suggestive of abnormality. That's all. It indicates arachnodactyly, long and slender fingers. That's all. Okay, treatment also is done. Another important syndrome probably you need to know is this one. What is this? Downs. And another important area where you cannot go without knowing this. Okay, Down syndrome is like in and out. If you are an undergrad, then it's even more valid. And if you don't know Down syndrome features, you can never pass. If they don't ask, it's fine. If they ask and if you don't tell, that's all. It's gone, done and dusted. You cannot help it anymore. Okay, what are the features of Down syndrome basically? And what is Down syndrome first of all? Okay, all right. It's trisomy 21. So quickly, like I'm not going to explain because I have only 5 minutes to complete the entire Down syndrome. So what will be the genetics of Down syndrome? Of course, increased maternal age is the main risk factor. First of all, Down syndrome is not an inherited syndrome. So don't think Downs is inherited. Downs doesn't have any inheritance pattern because it's a chromosomal abnormality. So many students, I don't know, suddenly if I ask in exams and all, that's how I confuse. And undergrad, generally I go for mock exams and all. When I go as a mock examiner, if I ask tell me the inheritance pattern of Down syndrome, they'll be like autosomal recessive, dominant, they will say something. It is not inherited. It's a chromosomal abnormality. Risk is not running in the family. Only one risk that is known is increasing maternal age. That's all. And that extra 21st chromosome, where it is coming from? Mother or father? Mother. Because mother ovum is the one that is there for a long time. Sperms are produced in the short run only. It's acutely produced. Ovum is there since birth. So as increasing maternal age, ovum is the one that is liable for this degenerative process. So the problem usually lies in the ovum only. It's not in the father. So that extra 21st chromosome, if they ask you where it comes from, it basically comes from the mother. Only 3% of the times it can come from the father. 97% of the time it's coming from the mother only. Okay. So there are 3 important genetics. So one is non-disjunction. That's called as meiotic non-disjunction, which is responsible for more than 95% of the case of Down syndrome, which means during meiosis, the chromosome number has to be halved. So 2 eggs will be produced. In that, one egg should contain 23, another egg also should contain 23. But unfortunately, sometimes during this meiosis, production of haploid chromosomes, haploid genome, your one extra 21 can come along with one of the ovum, and if that is fertilized, you will end up with Down syndrome. This error will increase as the maternal age progresses. That's the problem. So more than 95% of the time, it is meiotic non-disjunction. There is a second problem that's called Robertsonian translocation, which is rare. They won't ask you generally. And third is mosaicism, which happens after fertilization. Mosaicism generally happens after fertilization, not before fertilization. After fertilization, further in the blastocyst stage and all, division will happen. No, during that time, if you have defect, some abnormality happens, means that is what we call as what mosaicism. In mosaicism, what will happen? There will be 2 groups of cells, where some group of cells will have normal karyotype, another group of cells will have abnormal karyotype in the form of trisomy 21. So this group of children will not exhibit all the features, because whatever organs that differentiate from that abnormal cells only will exhibit what features, and whatever organs that differentiate from these normal cells may not have any problem at all. So that's what we call mosaicism. Problem happening after fertilization and during the very commonly in the early blastocyst stage. So if that happens, that is what we call mosaicism. So generally, Robertson translocation, mosaicism together constitute less than 5% of the cases. That mosaicism is the rarest. Okay, less than 1% of the times only you will end up with mosaicism. So what is the general risk? Increased age means if the maternal age is more than 34, the risk of Down syndrome is 1 in 400. If the maternal age is more than 40, the risk of Down syndrome is 1 in 105. If the maternal age is more than 45, the risk of Down syndrome is 1 in 12. As you can see, this is a clear evidence that maternal age is something that's going to influence the Down syndrome very, very much. As the age increases to more than 45, the risk of having Down syndrome is 1 in 12 births, which is again huge. Okay, what are the general features of Down syndrome, clinical features? So starting from neurological manifestation, remember Marfan syndrome is not a syndrome of mitral regurgitation. Sorry, mental retardation. MR means, like always comes mitral regurgitation only. Marfan syndrome does not produce mental retardation, MR. You don't have MR in Marfan, no MR. IQ is normal. That's why people suspect Abraham Lincoln as Marfan. How can he rule a country if he has a mental retardation? Okay, so Abraham Lincoln is supposedly to have a Marfan, but nobody has a clear literature about it. But based on his features, based on his problems that he faced, it's believed that he had Marfan syndrome. He had typical Marfanoid features. Okay, but Down syndrome, MR, definitely. Usually it will be moderate to severe. MR is a very important feature of Downs. Second is hypotonia. Especially at birth, you can see a very hypotonic baby, and in the body, they will have extremely high flexibility and protuberant abdomen. And in the foot, one important dermatoglyphics is what you will see. What do you mean by dermatoglyphics? Understanding the fingerprints. Okay, that's called, we call as dermatoglyphics. So some dermatoglyphics will be abnormal. For example, generally most of us, not most of us, almost all of us will have in the ball of the foot. What is ball of the foot? First metatarsal head. You can see, in your foot, in the first metatarsal head, that's called ball of the foot. There will be a whirl, okay, whirl pattern for most of us, even though pattern may be different, but the general thing that we see is a whirl. But these patients will have absent whirl. Absent whirl in the ball of the foot, that will be absent, typical. In fact, many research says that if this whirl is present, means it rules out Down syndrome. This is one of the consistent features of Down syndrome. If the whirl is there, if that whirl pattern is there in the ball of the foot, that actually rules out Down syndrome. And next, there will be something called a sandal gap. Generally, there will be a gap between the first and the second toe. I think in this baby, they have shown it. I think it's not very visible, but in this baby, there is some gap they have shown. I don't know. So this is the toes they have shown. So they have shown the gap. So there is a gap between the first and the second toes that is called as sandal gap. And next, brachycephaly. As we discussed already, Marfan's will have dolichocephaly, but these patients will have brachycephaly because of the coronal suture fusion. And this is one of the findings which has 100% incidence. Almost all the patients will have this brachycephaly. And when it comes to the face, inner epicanthal folds are common. There will be a fold of skin in the inner epicanthus. That's called as inner epicanthal folds. And as I told you, one of the other important feature is mongoloid slant. Did I tell you or not? Up slanting palpebral fissure. So Marfan, you have a down slanting palpebral fissure, whereas in Down syndrome, you have a up slanting palpebral fissure. This is called as mongoloid slant. And they can have esotropia, which is a type of squint. I'll talk about this in neurology. Esotropia and exotropia is there. Esotropia is a kind of squint only. And one other interesting feature is called brush field spots in the iris. Okay, brush field spots. These are hypopigmented speckled spots called as speckled and hypopigmented spots, otherwise called as brush field spots. Then patients can have macroglossia. These are all in the face. Macroglossia, large tongue. One of the important DDs for macroglossia. Remember, in exam, they will ask you, what are the DDs for macroglossia? What all you can say? Congenital hypothyroidism. Large tongue, very common. Congenital hypothyroidism. Then Down syndrome. Then acromegaly. Then amyloidosis. Okay, these are the 4 important DDs for a macroglossia. Very large tongue. Downs, congenital hypothyroidism, acromegaly, and amyloidosis. So one of the important disorders that produces macroglossia, large tongue. And patients can have high arched palate. If you take the systemic features, these are the general appearances. Okay, when you go inside the body, so what are the problems they're going to face? CVS problems. Remember, more than 50% of the Down syndrome patients will have some sort of CVS abnormality. The most common is endocardial cushion defect, or we can say VSD. VSD is the most common abnormality. This is followed by atrioventricular cushion defects. But AV cushion defects are considered to be very specific for Down syndrome. But even though VSD is the most common cardiac abnormality, very, very common. Almost in India, I've seen like 10, 15 Downs, and almost every one of them had some cardiac problem, especially VSD. So common. And coming to endocrine abnormalities. Endocrine abnormalities, hypogonadism is a universal feature. Hypogonadism, 100%. Remember, nature itself tries to stop, reproduction in these people. Generally, if there is any chromosomal abnormality, you will get aborted mostly. The most common mechanism of eliminating this kind of, you cannot say disabled, maybe differently abled is the right name, no? Right now. So these kind of people, nature itself will try to stop from coming out. So majority of the times, they'll have this first trimester abortion. The usual reason is chromosomal abnormalities. Suppose if they somehow get born also means they will be hypogonads. They will not be able to reproduce. They will be infertile only. Take Turner syndrome, for example. They will not be able to reproduce. They'll have streak gonads only. Most of the chromosomal abnormalities, you can think as a kind of a defense act from nature to prevent these individuals from populating the society. That's the idea. But it's believed that males definitely cannot reproduce. But if it's a female child, it's been shown that 50%, 50% of the female children will be able to give birth to an offspring. And in those 50% who are reproducing, the chance of subsequent Down syndrome in the child is 50%. If it's a female only, males definitely can't reproduce. 100% no. Females possible. in 50%, they can give rise to an offspring. But in that 50%, there is a 50% chance of developing Down syndrome is there, which is abysmal, again, very high. And hematological complications are also, lots are there. The most important hematological complication is polycythemia. This will be followed by iron deficiency anemia. And one important leukemia that comes in this, guys, is acute myeloid leukemia, very commonly M7 variant, which is actually quite rare, but in Down syndrome patients, it's common. AML M7. That is a megakaryocytic variant. I think you would have studied in pathology. M1, M2, M3, M4, M5, M6, M7. M7 is a megakaryocytic variant. Acute megakaryocytic leukemia. This is quite common in patients with Down syndrome. And one more important thing is, I didn't say this, Down syndrome patients are very much prone for early dementia. As early as 40 years. And that's because Alzheimer's disease, the basic pathophysiology is what? Amyloid precursor protein that is giving rise to A beta amyloid. This is the basic pathophysiology for development of Alzheimer's disease. More A beta amyloid. That's the pathophysiology. If you ask where APP is coming from, amyloid precursor protein is coming from, it is coming from chromosome number 21. So these patients are having 3 chromosome number 21. So naturally itself they will produce excessive amyloid precursor protein and there will be more A beta amyloid production. So they are prone for developing early dementia, early Alzheimer's disease by around 40-45 years of age itself. The average life expectancy of patients with Down syndrome is 50 to 55 years as of now. The modern practice, the average life expectancy of Down syndrome is approximately 50 to 55 years, and majority of them will develop so many complications. And therapy is very important. Therapy will not be directed against Down syndrome, will be directed against the complications. Especially the speech and behavioral therapy are very, very important. And Down syndrome patients are supposed to be very friendly, as opposed to many other syndromes where the children will be very aggressive. Down syndrome patients are MR only, but they'll tend to be very friendly and jovial to everyone. And there are 2 syndromes where people are liable to abuse. One is Down syndrome because they're very friendly. Second is Angelman syndrome, where there is no MR, but they will be, one of their characteristic features of Angelman syndrome is they tend to be extremely friendly. And they'll be laughing all the time. You would have studied, no? Happy puppets. And that is the reason why they are liable for abuse. Angelman syndrome. And they will start trusting easily everyone. I mean, there might be some Angelman syndrome sitting here also, but okay, fine. I don't want to say. So what are the screening protocol? So you have something called triple screening and quadruple screening. So currently what is preferred is quadruple screening. So what are 4 things that is there? One is alpha fetoprotein. Second is HCG, beta HCG. Third is inhibin A. And fourth is unconjugated estradiol. So you can write as UE3. Okay, unconjugated estradiol. So these are the 4 things that is used in quadruple screening. So whenever there is abnormality in alpha fetoprotein, what are the syndromes? Downs, Edwards, and neural tube defects, NTDs. All these things can have abnormalities in the alpha fetoprotein. Beta HCG generally will be abnormal in Down syndrome and Edwards syndrome. Inhibin A will be abnormal in patients with Down syndrome, and I can write all 3 this thing together. That's better. So HCG, inhibin A, and unconjugated estradiol, all these things will be abnormal in Down syndrome and Edwards syndrome. So Edwards syndrome is what? Trisomy 18. Easy mnemonic, isn't it? Edwards 18. E for E. Patau is 13. Because Edwards doesn't have T, Patau has T. 13 as T. Right? So these are the important screening tests that we use. Other things that have been utilized is PAPA, or called PAPA. What is that? Pregnancy associated plasma protein A. That is PAPA. This also has been used. And screening should start by around 9 to 11 weeks. Generally, what they do at around 9 to 11 weeks, they look, this is called as NT scan. Everyone knows that. Most of you would have studied in OBG. At around 9 to 11 weeks only, are going to push the lady for NT scan, that is nuchal translucency. Plus, we will do beta HCG and PAPE. So this is what we prefer by 9 to 11 weeks. And what is the sensitivity of nuchal translucency? Sensitivity is approximately 80% and has a very high false positive rate. False positive rate is very high. So it cannot confirm that the patient is having Down syndrome or not, and the sensitivity is also not so good. It's only 70%. And another thing that you can notice, absent nasal bone, which also has a not very good sensitivity, but a decent sensitivity of 70%, absent nasal bone. Remember, this quadruple screening is generally performed in the second trimester. NT scan only is performed in the first trimester, whereas this quadruple screening is performed in the second trimester basically. So what will be the features? Okay, if you write Downs on one side, and if you write trisomy 18, that is Edwards on other side, and if you write NTD, neural tube defects on other side, what all will be the abnormalities? In alpha fetoprotein, beta HCG, inhibin A, and unconjugated estradiol. So Down syndrome, alpha fetoprotein will be less, HCG will be high, inhibin also will be high, whereas estradiol will be low. This pattern you should definitely know for exam. There's nothing you can do about it. 2 will be low, 2 will be high. Whereas in Edwards syndrome, all will be low except inhibin A, which will be normal. All will be low except inhibin A, which will be normal. In neural tube defects, your alpha fetoprotein will be high, other things will be normal. So this is a common question. High alpha fetoprotein is an indication of neural tube defects. Because in Edwards and Downs, your alpha fetoprotein is low. Whereas in neural tube defects, your alpha fetoprotein levels will be high, increased. What are neural tube defects? Anencephaly, spina bifida, meningomyelocele. All these things are neural tube defects. So where alpha fetoprotein will be high. Very, very important question. So this can be asked in OBG also. This can be asked in your pediatric questions also. Even adult medicine itself, they are asking, then what about pediatrics? Definitely they will ask. Screening for Downs. What are the, if you take only Downs, what are the features? We have a low alpha fetoprotein, whereas your beta HCG and inhibin A levels will be increased, but your unconjugated steroid levels will be low, and nuchal translucency may be increased, and patients may have an absent nasal bone on the screening. And quadruple screening ideally performed in the second trimester. That's all. This is all about Down syndrome. You cannot ignore Down syndrome at all at any cost, definitely. Then what about another important syndrome, that is Turner syndrome? Again, Turner syndrome, I can take it for 1 hour also, but I have to finish in 5 minutes. What are the important components of Turner's? So this is one important component, which is also a marker of congenital heart disease. What is that? Widely spaced nipples. You can see another girl here. Widely spaced nipples. So what is the definition of widely spaced nipples? Objectified. Objectify. What is the definition of widely spaced nipples? This is called as internipple distance, right? Internipple distance. If your internipple distance is divided with chest circumference of the chest, if it is more than 0.25, if it is more than 25%, that is suggestive of widely spaced nipples. If the internipple distance is more than 25% of the chest circumference, that is suggestive of widely spaced nipples. So all these things are suggestive of Turner syndrome. Usually it's a kind of spotter. You can see this shield chest. Shield means the chest will be like this. It's not carinatum or excrotum, but generally chest will be like this. That's why we call it a shield chest with increased internipple distance, that is widely spaced nipples. Along with that, patient will have no breast development because these patients don't have ovary. Because these patients don't have ovary, they don't develop any secondary sexual characters of a female. So absent breast development, one of the important cause of primary amenorrhea. Not important, it's the most common cause of primary amenorrhea in the world right now is Turner syndrome. That's why it's important. And genetics is very difficult, so I'm not going to go into the genetics, but you all know the karyotyping is going to be monosomy X. First important feature is short stature. Okay, this is the most common feature of Turner syndrome, affecting almost 95 to 100% of the individuals. And how much they grow less? That's a question. 20 centimeter less than their peers. Final adult height will be 20 centimeter less than their normal adult counterparts, approximately. This was the exact question that was asked in my pediatric medal exam. I didn't get a medal in pediatrics, of course, but this was the question that was asked. How much? Exactly around 20 centimeters less than their adult counterparts. That is the number. Second, widely spaced nipples. With shield chest and poor breast development. Poor or absent breast development. And most of the patients will have primary amenorrhea. They will never get menses at all because no estrogen. Because streak ovaries, streak gonads. And this can result in a lot of complications. And they can go for early osteoporosis. And they can even start getting menopausal symptoms at a very tender age. Okay, osteoporosis. And another important feature is cubitus valgus, excessive carrying angle. You would have studied that, as you can see here. You can see wide carrying angle, which is a usual feature of females itself. But in Turner syndrome, it will be even more exaggerated. Increased carrying angle and cubitus valgus. And there are some other features like webbing of the neck. Webbing of the neck. And plus or minus hand also can be there. And generally, this webbing of the neck correlates with cardiovascular abnormalities. If there is webbing, that increases the risk of CVS anomalies. That has some correlation with cardiovascular problem. So now systemic features. What are the cardiovascular problems? Generally, there will be left-sided problems. What are left-sided problems? Bicuspid aortic valve followed by coarctation of aorta. Technically speaking, most common will be transverse aortic arch. Aortic arch normally should be nice like an arch, right? But in this patient, there will be a straight transverse aortic arch. But that does not lead to any complication. That's why people don't say it as a disease. But technically speaking, transverse elongated and transverse aortic arch is the most common cardiovascular abnormality. But if you ask about the things that give trouble to these patients, it is bicuspid aortic valve and coarctation of aorta. So if you see, all are left-sided problems, left ventricular left-sided problems. This is very important because we are going to discuss about Noonan syndrome, which has right-sided problems like pulmonic stenosis. That's why I told you specifically it has left-sided problems, bicuspid aortic valve and coarctation of aorta. Then you can have renal issues. Very commonly a horseshoe kidney. I mean, not commonly. They ask you most common, once again, is collecting system defects. But exam, if you say collecting system defects and all, they will then ask you unnecessarily, they will torture you. What are collecting system defects? So just mention horseshoe kidney and move on. But most common, technically speaking, it is collecting system defects only. Then coming to ocular problems. Myopia and strabismus. What are the ear problems? They'll get recurrent otitis media and sensory neural hearing loss. What are the skin problems? They can get multiple pigmented nevi. And what are the autoimmune problems? Turner syndrome patients are prone for developing a lot of autoimmune problems also, like thyroiditis. They can develop autoimmune thyroiditis like Hashimoto's and hypothyroidism, or even Graves' disease and hyperthyroidism, followed by celiac disease. They are at risk of developing celiac disease also. That's why even for adults, this is very important because most of the Turner syndrome are managed by adult endocrinologists and adult physicians only, more than pediatric children, pediatricians. Because most of this problem will mount in the adolescent period. That's why for adult physicians also, understanding Turner syndrome is very important. But recognition of Turner syndrome as a child itself is important because there are some therapies so that you can improve the height of the individual. That short stature to some extent can be ameliorated by giving growth hormone therapy and all. So that's why recognition as a child itself is very important. But most of the times, as an adult practitioner also, you need to be you need to be seeing a lot of Turner syndrome. But what are the cornerstone? I mean, if you want to say only 3 important features of Turner syndrome, first one is short stature, second one is this gonadal dysfunction, and the third one is going to be cardiovascular abnormalities. So these are the 3 characteristic features of Turner's. If you want to say only 3, which are very, very important for Turner's, that is short stature, gonadal dysfunction, and cardiovascular problems. Very typical of Turner's. Okay. And there are 2 criteria. I'm not going to tell the criteria because it's not required. As far as Down syndrome diagnosis is concerned, it's been proposed actually. One is called as Hall's criteria. HALLS. Hall's criteria. And second one is called as Fried criteria. Fried's criteria. I don't know how do you pronounce it, Fried or Fried. So FRIED, that's all. Nothing much. I don't know how to pronounce it, Fried or Fried. So Fried's criteria and you have Hall's criteria. 2 important criteria are there as far as Turner syndrome, Down syndrome is concerned. So once you discuss about Turner, automatically your discussion will move towards another syndrome called Noonan syndrome. So Noonan syndrome is often called as, like a male Turner, very commonly. But I won't call by this name. I hate that name. Noonan syndrome is not male Turner at all because there are so many differences with that of Turner. For example, Noonan syndrome is not a chromosomal defect. The genetics itself is different. Turner is chromosomal defect. Noonan is never a chromosomal defect. And Noonan is a autosomal dominant inherited condition. Turner is not an inherited condition. And there is a specific gene that is defective because it's autosomal dominant. It is PTPN11. So I told you, for craniosynostosis syndromes, it is FGFR2. Likewise, in Turner syndrome, it is PTPN11, protein tyrosine phosphatase gene. Okay, that is the one that is defective. And Noonan syndrome patients will have cardiac features, but the cardiac features will more involve right-sided structures than the left-sided structures. Most common abnormality will be primary pulmonic stenosis. Turner's, it is left-sided, right? Whereas in Noonan syndrome, it will be right-sided involvement. Most common cardiac abnormality in Noonan syndrome will be primary pulmonic stenosis. Sometimes you can have hypertrophic cardiomyopathy also. Rarely, but this is the most common, primary pulmonic stenosis. And please understand, these patients will have normal ovary and normal testis also. Why I said that point? Because Turner syndrome can affect only females. Whereas being an inherited problem, Noonan syndrome can affect both males and females, which means they are fertile. Turner syndrome patients are fertile or infertile? Fertile or infertile? Infertile. But with advanced therapies, like Turner syndrome patients are able to conceive nowadays with a lot of advances, surrogacy, so many things are there. So we can try to extract, because what is believed to have, the reason for gonadal dysfunction Turner's is, this is too much, but still, accelerated destruction of the eggs. So it's believed that Turner syndrome individuals also start with the same number of eggs as an embryo, like you and me. Maybe like you, she and her, maybe I should not say you and me, okay? Like you both, like Turner syndrome patients also will be born with almost, as an embryo, they'll have same amount of eggs in the ovary. but there are some reasons which is largely unknown, which causes accelerated destruction of these eggs as an embryo itself. When they come out itself, they have very, very poor egg reserve. As they grow up, it becomes worse. So if you can identify this disorder much early as 1 year or 2 years, you can try this egg preservation techniques and all. You can try taking these eggs and cryopreserve it. Maybe in the later you can use, and because these people will have reasonably normal uterus, so probably you can try giving hormonal therapy, because hormone replacement therapy is very commonly used in Turner syndrome patients because they don't have estrogen. So with the same combination, you can even try making them conceive, which is quite possible and logical also. Okay, it's pretty okay, isn't it? Okay, that's all. So these patients will be fertile. That's why it's not good to call this Noonan syndrome as male Turners in the first place, because there are a lot of differences will be there. And what are the common features with Turner syndrome? Because of that, we are calling it as male Turners. One is short stature. Second is your webbing of the neck. Webbing of the neck and probably hand is common. This is a common feature between both Turners and Noonan. That's why it's commonly called as male Turner. But understand, it can affect females also. Clear? So when you talk about PTPN11, the same gene is responsible for causing another syndrome called as Leopard syndrome. Leopard syndrome. So many people believe that Leopard syndrome is actually a variant of the Noonan syndrome only. So Leopard, L stands for lentigens. So people call Leopard syndrome as Noonan syndrome with multiple lentigens. Okay, what L stands for here in Leopard syndrome? It's the same PTPN11 only as that of Noonan's. L stands for lentigens. E stands for ECG abnormalities. O stands for ocular abnormalities. P stands for pulmonic stenosis. Because PTPN11, see, remember, PTPN11, pulmonic stenosis. Leopard syndrome. And A stands for ocular, then pulmonic stenosis, then A, abnormal genitals. I think I'm right. Okay. Abnormal genitals. And D stands for, I think R is there. R stands for mental retardation, MR. And D stands for deafness. This is Leopard syndrome. Lentigens, ECG abnormalities, ocular abnormalities, pulmonic stenosis, abnormal genitals, mental retardation, and deafness. Leopard syndrome. Again, it is due to PTPN11 only. You are going to get the same problem as that of what you are going to get in Noonan syndrome, but with some additional problems. Say people think like this Noonan, this is just a variant of your what is that? Noonan syndrome only, because of the same gene that is involved, PTPN11. So these are the least minimum syndromes that you need to know for exams. Marfan, Downs, Turner, Noonan, Leopard. For additional marks, if you want to know, there is something called velocardiofacial syndrome. That's called velocardiofacial syndrome. So remember, velocardiofacial syndrome is a diverse entity. So in most of these things, there will be a poor development of the pharyngeal arch, especially as I told you in the afternoon itself, third and fourth pharyngeal arches will not develop properly. This is also called as VCFS. It's a very diverse syndrome, velocardial facial syndrome. And most of the times, there will be something called as micro deletion of chromosome 22q11.2. Even in D. George syndrome, if you take and see, the same chromosome deletion will be happening. So there will be micro deletion at 22q region, 11.2 area. So that gives rise to a constellation of syndromes. So velocardial facial syndrome has multiple problems. It can literally affect any organ. More than 180 phenotypes have been described in VCFS. But some of the important phenotypes that we need to know are Charge syndrome. And second one is D. George syndrome. D-George syndrome. And probably third one is Peary-Robin sequence. Peary-Robin sequence or Peary-Robin syndrome. So Peary-Robin is not related to cardiovascular problem. First of all, you need to know there is absolutely nothing to do with cardiovascular problem. So it's a kind of a triad, as everyone knows, where the patient will have micrognathia, glossoptosis. Glossoptosis means the tongue will frequently fall backward into the pharyngeal cavity, okay, causing airway obstruction. That is the third part of the triad. Micrognathia, that is very small mandible. Along with that, glossoptosis, that is falling of the tongue back into the pharynx, causing airway obstruction. This is the typical triad of Peary-Robin sequence. Or you can have something called charge association. Remember, charge and D-George syndrome are basically not inherited. And majority of the velocardial facial syndromes are not inherited. It happens in a sporadic fashion, new mutations. It's very can be inherited in very few cases, but majority, more than 95% of the times, it will not be inherited. It will be due to a new mutation somewhere, microdeletion. Charge association, C stands for coloboma of the eyes, coloboma. And H stands for heart defects. A stands for choanal atresia. Yesterday we studied, no? Choanal atresia produces cyclical cyanosis. So same thing, choanal atresia. And R stands for reduced growth. Okay, short stature, reduced growth. And G stands for genitourinary abnormalities. GU abnormalities, genitourinary abnormalities. And E stands for ear abnormalities. Ear abnormalities. Coloboma, heart abnormalities, atresia of choana, that is choanal atresia, reduced growth, genitourinary abnormalities, and ear problems. Okay, so this is called as charge association. And in pediatrics, you will study something called Vactal association also, which is associated with some esophageal problems like tracheoesophageal fistula and all. So I'm not going to discuss that. D-George syndrome. Same, in D-George syndrome, you will see the same issue, but D-George syndrome is very, very important topic for your exam 5 mark, 10 mark question also. So it is an immunodeficiency syndrome. Basically, you can remember as a mnemonic called what? Catch 22. Because 22 is easy because it's a chromosome number 22 problems. That's why it's called catch 22. So C stands for cardiac defects. A stands for abnormal face. And T stands for thymic hypoplasia. Thymic hypoplasia. Another C stands for cleft palate. And H stands for hypocalcemia. Hypocalcemia. Because your cells that secrete calcitonin, that is your C cells of the thyroid gland, they also arise from third and fourth arch only. So that is the reason, because of the abnormalities of the third and fourth arch, they may have abnormal calcitonin metabolism. Because of that, they can have hypocalcemia. That's what is believed to be. And parathyroid hormone levels will be low. More than calcitonin, parathyroid hormone levels will be low. Because of the low PTH, they tend to have hypocalcemia. Because parathyroid hormones also tend to develop from it's actually parathyroid only. Calcitonin is for Williams syndrome. I only confused. Maybe post-lunch session, no? I'm a little shaky. Okay. So calcitonin is for Williams syndrome. Calcitonin mechanism. This is for D-George syndrome. So patients, because of thymic hypoplasia, they will be having what? Immunodeficiency also. And they can have recurrent infections because of the same. And their T cells will be poorly educated. So it's a problem of T cell. It's a T cell defect. Because of T cell defect, they can have recurrent infections. So that's the mnemonic, catch 22. That is for D-George syndrome. And many syndromes are there, but these are the 3 important phenotypes as far as this velocardiofacial syndrome is concerned. So if you want to know Vactal association also, which will have tracheoesophageal fistula. That's additional that you need to know. Apart from that, charge I told you, D-George I told you, Peary-Robin sequence also I told you for exam. Next important syndrome is Williams syndrome. Because whenever you discuss about aortic stenosis, definitely they will ask you Williams syndrome. Because when you discuss about ASD, Holter, 100% they will ask. When you discuss about MS, they will 100% ask Lutembacher syndrome. When you discuss about DS, surely they will ask when you discuss about AS, definitely they will ask Williams syndrome. When you discuss about AR, they will definitely ask Marfan syndrome. That's why I'm telling all these things. When you discuss about MR, surely they will ask about Marfan or probably even other condition disorder related syndrome. So that's why you need to know. So Williams is, I can remember as a triad, basically. So what is the three components of the triad in Williams? One is the typical Elfin facies. Elfin face in Williams. Okay. And what is the problem? Which area the problem is? Like how you have a micro deletion of chromosome number 22 in your velocardiofacial syndrome and D-George syndrome. Likewise, there will be a micro deletion at chromosome number 7. I think it's somewhere around 7q1123. I think so. I'm not sure, but 7 I'm sure. Okay, it's somewhere around chromosome number 7. Okay, but definitely the long arm only, Q only, but 11.23 only confirmed later on. So definitely somewhere in chromosome number 7, there is a micro deletion that is resulting in the development of Williams syndrome. One is Elfin face. So why it is called Elfin face? I mean, where it is inspired from? In German mythology, there is something called as elves. There is a group of supernatural people called elves, ELVS, and you have a lot of web series also based on that. Have you seen that? Elves web series. So they look like that. That's why these are called as Elfin facies. And second, they will have one cardiac problem called as supravalvular aortic stenosis. I'll talk about that later in the evening. Supravalvular aortic stenosis. Next, hypercalcemia. Here only your calcitonin comes into play. I told wrongly for this thing last time. D-George PTH abnormality will be there. Whereas here there will be abnormal calcitonin. Calcitonin is known to reduce the calcium levels. Because of abnormal calcitonin metabolism here, your calcium levels will be high. Your calcium levels will not be suppressed. So that will result in the development of hypercalcemia. This is typical of Williams syndrome. Okay, and this is another example of a guy who had a low set tears. As you can see, when you draw a line, real-time example, I didn't show you. If you draw a line from the outer canthus, normally it should be like this, right? Ear should be something like this. But in this situation, ears are much below. So definitely this is an example of low set ears. Okay, this is an example of Elfin face. Elfin facies. What are the characteristic features of Elfin facies? One is periorbital puffiness. That is not shown, unfortunately, here. You are not seeing the periorbital puffiness. And there will be epicanthal fold that is also masked here, unfortunately. Patients will have hypertelorism. One of the other disorders that produce hypertelorism is Williams syndrome. Patients will have a depressed nasal bridge. Patients will have a prominent lower lip. As you can see here, lower lip will be extremely prominent. In this child, can you see the malar prominences prominently, or you are not able to see the malar prominences? You are not able to see the malar prominences at all. I mean, compare with Katrina Kaif or Kareena Kapoor, then you will be able to understand properly. You're not able to see the malar prominence properly, isn't it? So which means it is malar hypoplasia. This is a very common symptom, common sign. And patients will have a very wide mouth. Mouth will be very wide like Joker. Patients might have variable degree of mental retardation also. MR is also quite common. And apart from that, so many problems. Neck problems can be there. Teeth malocclusion can be there. Teeth may fall early. So many problems these patients will face. But nevertheless, these are the important features of Elfin face. So periorbital puffiness, depressed nasal bridge, epicanthal folds, thick upper lip, wide mouth, teeth problems, okay, malar hypoplasia. So these are typical elephant faces features. And there is another face called as conotruncal face. And this is an example of Noonan syndrome basically. I told you one more picture I think I've shown. Yeah. This is a picture of Noonan syndrome. And patients will have some characteristic phenotype. One of the important phenotype is very large head. They'll have very large head. And can you see the low set ears here also? Are you able to see or not? Are you able to see? Low set ears. See how much low the ears are. Okay, there will be significant low set ears. Okay, and the hair might be little woolly. Woolly means like wool-like. And nasal root will be depressed, like what we saw in Williams syndrome. The nasal bridge will be depressed as well. These are typical Noonan's face. Noonan's very large head, depressed nasal bridge, low set ears, and they might have webbing of neck also, along with short stature, like Turner syndrome. So a lot of features may overlap, but at least the large head and the depressed nasal bridge with low set ears should be known, at least. These are the characteristic features of Noonan's. Typical Noonan's face. What is this? By seeing itself, we should be able to say. I'm saying this is associated with the ASD. Now easily you can say, what is this? Holt-Oram syndrome. Holt-Oram syndrome. Usually, upper limb abnormalities are common. ASD is an associated feature, plus patients will have upper limb abnormalities. So this upper limb abnormality can be as bad as absent radius to absent thumb, or it could be little mild like short fingers, brachydactyly. So they can be very bad, like what? Complete absence of radius and thumb. So radius is here, right? Along with radius, the entire thumb may be absent. That's very bad. That's a more severe phenotype. Or alternatively, they can have brachydactyly, small fingers. This patient is having a smaller ring finger, little finger, pinky. You can see, very small little finger is there. Plus, apart from that, one more interesting thing that you're noting is the plane of the thumb is rotated. Normally, what is the plane of the thumb? The plane of the thumb is perpendicular to the normal plane of the hand. You all know that, right? That's a very important evolutionary advantage God has given to us, or nature has given to us, whatever. See, remember, it's believed that this rotation of the thumb is there, no? This thumb is that is perpendicular to the plane of the palm is a very big evolutionary advantage. And some scientists say if that has not happened, means we would have still been apes. We would have still been apes, because this rotation of the thumb only given us advantage of this opposition. With opposition only, you collected objects. You started using those objects in a very fine manner. You start using the pen. Some example I'm telling. So using the tools, everything is because of what? Opposition and this rotation of the thumb only. If this does not happen, if this has not happened, means we would have still been apes. We would not be able to add any of this revolution that we are having right now. So it's one of the biggest evolutionary advantage we ever had after becoming the two-legged organisms. So these patients will not have that evolutionary advantage, which means the thumb will be in the same plane as that of the palm. That's called as ape hand. It was studied in median nerve palsy in first year anatomy itself, ape thumb deformity. See, this patient, they will not have median nerve involvement, but still their thumb will be in the same plane as that of the palm of the hand. As you can see here, right? So it's rotated. It's not like normal thumb. It's in the same plane as that of the palm. That is very typical of Holt-Oram syndrome. When you discuss about ASD, 100% you will get this question. If your case is ASD, or anywhere if your discussion goes towards ASD, surely you will get this question, Holt-Oram syndrome. Okay. That's all. I think it's over. The final, only one thing that we need to discuss is Ellis van Creveld. What is this? Final thing is Ellis-Van Creveld syndrome. So usually these patients will have significant short stature. Short stature. Short stature in the sense there are different types of dwarfism. One is called as proportional dwarfism. Another is disproportional dwarfism. You would have studied in pediatrics. Disproportional dwarfism means either your lower limbs can be abnormally short or your upper limbs can be abnormally short. If your lower limbs are abnormally short, it is called as what? Mesomelia or mesomelic pattern. If your upper limbs are abnormally short, it is called as what? Rhizomelia. Proportionate dwarfism is different. If it's a disproportionate dwarfism, it is further divided into mesomelic pattern and rhizomelic pattern. If the lower limb is abnormally short, that is called as mesomelic dwarfism. The characteristic example of mesomelic dwarfism is Ellis-Van Creveld syndrome. That is the reason why they asked this question. And what is the characteristic example of rhizomelic dwarfism? Achondroplasia. That's why that question is very important. These are characteristic patterns. These are classic literature evidences. That's why these questions are very common in your exams also. The classic example of mesomelic dwarfism is Ellis-Van Creveld. The classic example of rhizomelic dwarfism is achondroplasia. Okay, both are very important. And why Ellis-Van Creveld is very important? Because it is associated with some cardiac problem. What is the cardiac problem? ASD, atrial septal defect. If I am the examiner, surely I will ask this. I will not ask Hall-Torrem syndrome because I know you will be surely knowing that. So I will definitely ask Ellis-Van Creveld syndrome. Apart from that, patient can have this kind of, like very abnormal teeth. As you can see, like dental malocclusion is extremely common. They will have complete absence of upper incisors. They're not at all having upper incisors. And they will have this conical lower incisors. Like rat-like appearance is there, no? So upper incisors is completely lost and lower incisors is not there at all. Patient can have short ribs. Patients can have polydactyly. Okay, polydactyly is again of two types, post-axial and pre-axial polydactyly. So these patients will have post-axial polydactyly. Post-axial means outside the little finger. That is post-axial. Pre-axial means near the thumb. That's called pre-axial polydactyly. These patients will have post-axial polydactyly near the thumb, near the little finger. After the little finger, one extra finger may be there. So these are very common things. Short ribs, short stature, dwarfism. And what is this example? You can say this pretty easily on seeing that. The first one. I've told you some time back. What you're seeing in the face? Multiple dots you're seeing. What is that? This is lentigens. What is that? Leopard syndrome. What is the gene mutation? PTBN 11. That's all.